Okay, so our next clinical correlation is atrioventricular conduction. Here's case number 6. Mr. Mueller is an 85-year-old male with a history of appendectomy, remotely, and hyperlipidemia. He has been healthy most of his life and has seldom needed medical attention. In a routine clinic visit today, he notes that for the past 4 months, he has felt progressively more fatigued. He notes he is now having trouble climbing stairs to his apartment and has had several near syncopal episodes recently. He has no family history of heart disease. Physical exam shows an elderly male in no acute distress, resting comfortably. Vital signs: temperature is 97 degrees Fahrenheit, pulse is 40, respiratory rate is 20, blood pressure is 125/75. His neck is supple with no bruise. He has regular bradycardia, a normal S1, S2, no rubs, clicks, or murmurs. His abdomen is soft, non-tender, and non-distended. Extremities are dry, and he has no edema. The ECG shows the following. The ECG shows which diagnosis? A, first-degree atrioventricular block, or AV block. B, second-degree AV block, type 1, Wenke block. C, second-degree AV block, type 2. D, third-degree AV block. Or E, fourth-degree AV block, latency. And I'll go back to the ECG. Okay, so the answer is third-degree AV block. And just for the record, there's no fourth-degree AV block. This is just a distractor. So let's look at the ECG. So we see on the very left of the ECG a P wave, and it has no QRS that is tethered to it, and essentially there's no response for the next 600 to 800 milliseconds, or 3 to 4 large boxes. And then you see a QRS, and immediately nestled within the QRS is what looks to be the same P wave. So the P wave is coming directly on the QRS and could not have resulted in the QRS. In fact, it actually trails the QRS. And then we go along and we see the next P wave, and which could ostensibly be coupled with the next QRS, not necessarily. But then you see another P wave, and there's no QRS coupled with it. And so you see this dissociation between a faster P wave rate, or the P to P interval is shorter, and then a much slower ventricular rate with a much more spaced out QRS to QRS interval. So this is essentially a third-degree AV block. This means that the atria are driving the atrial rhythm, but there's no electrical signal that gets down through the AV node into the ventricles and causes the ventricles to follow. So the next step in this patient's management is A, a cardiac resynchronization pacemaker, B, implantable cardioverter defibrillator, or ICD, C, a single-chamber pacemaker in the atrium, D, a single-chamber pacemaker in the ventricle, or E, a dual-chamber pacemaker, which is placed in the right atrium and the right ventricle. So the correct answer is dual-chamber pacemaker. So essentially, a dual-chamber pacemaker is where you have one lead or electrical wire in the right atrium and one lead in the right ventricle. And so this is essentially an electrical bypass of the AV node. Now, typically when we talk about a bypass, we talk about coronary artery bypass. But if you think just a little bit differently, a pacemaker, especially a dual-chamber pacemaker, is like a electrical bypass of the AV node, where you have proximal electrical control of the atria and then distal electrical control of the ventricle. And so, per the guidelines, a permanent pacemaker implantation is indicated for third-degree and advanced second-degree AV block at any anatomic level, associated with arrhythmias and other medical conditions that might require drug therapy, or that results in symptomatic bradycardia. And remember, in our patient, he had symptomatic bradycardia and also a third-degree AV block. So the answer is a dual-chamber pacemaker. Here's case number 7. Miss Iwu is a 27-year-old female with essentially no past medical history who presents for complaints of palpitations. She notes that she has had some intermittent palpitations as a child and teenager, but more recently she has had prolonged and sustained palpitations that last for several hours. These episodes are associated with a pounding sensation in the chest and some lightheadedness. Triggers include stressful situations or running, and relieving factors include rest or vagal maneuvers. Palpitations typically occur with a sudden onset and terminate with a sudden offset. Physical exam is essentially normal, with normal vital signs, a supple neck, no bruits. The cardiovascular exam is normal with regular rate and rhythm, normal S1, S2, and no rubs, clicks, or murmurs. She has clear lungs, a soft abdomen, and well-perfused extremities with no edema. Her ECG shows the following. So her ECG findings are most consistent with which of the following? A. Ventricular hypertrophy. B. Myocardial ischemia. C. Ventricular pre-excitation or Wolff-Parkinson-White. D. Early repolarization syndrome. E. Brugada syndrome. So the answer is C. Ventricular pre-excitation and the Wolff-Parkinson-White syndrome. So if we go back, we can see in this ECG that we have a P wave that's kind of flat, and then we see that there's a short PR interval between the P wave and the R wave. This is very short. It's less than 120 milliseconds. And then we see this slurred wave that goes directly up to the R wave in lead 1, and you can even see a better short PR interval and a slurred delta wave that occurs here from the P to the R. This is a delta wave and is pathognomonic for ventricular pre-excitation that happens from an accessory pathway. The accessory pathway essentially speeds up electrical conduction from the atrium to the ventricle and beats out the AV node, and this early electrical stimulation of the ventricle is called pre-excitation. Now, the Wolff-Parkinson-White syndrome, as we can see here, that is a syndrome of palpitations or other symptoms that is associated with arrhythmias that come from an accessory pathway. So if you have an asymptomatic accessory pathway, then there's not really a syndrome of Wolff-Parkinson-White. But if you have an accessory pathway causing this delta wave on the ECG, and then that is associated with symptoms like palpitations, dizziness, passing out, etc., then that's the Wolff-Parkinson-White syndrome. So the next logical step in the patient's management would be A. Oral beta blocker, B. EP study and ablation, C. Reassurance, D. Echocardiogram, or E. Cardiac catheterization. The answer is EP study and ablation. So essentially, when somebody has an accessory pathway and then they have palpitations, this is usually presumably from atrioventricular reciprocating tachycardia, usually in the orthodromic direction, meaning it's coming down the AV node and it causes a narrow QRS. And so when you have orthodromic AVRT, which occurs from, again, the electrical signal coming down the AV node and up the accessory pathway, then they usually have pre-excitation on a resting ECG. And in a patient who has symptoms, the first-line therapy, the class 1 indication, is for catheter ablation. Now, if a patient has symptoms and they don't want an ablation, then you can consider other treatments like antiarrhythmic drugs like flecainide or rate-controlling drugs like beta blockers. But really the first-line therapy, if the patient is amenable, is catheter ablation through an EP study.